time. Based on our time and the number of slides I have, we're going to fly through some of these. I'd ask everybody to put a little different hat on. We're going to talk about quite a bit of, after you get done with your patients, where do they go to after they leave the hospital? I have no financial relationships or commercial interests. Special thanks to the AAMC. I did a fellowship with them in 2015. And thanks to Dr. Quinones, Meyer, Ramos, Freshenda, Claudia, and Sydney for their helps with these. Goals: what is post-acute care? In other words, after they leave our hospital, what's changing in it? Why is it important? And what are some of the next steps? And why is it important to you as well as your patients? Well, if you look at post-acute care, as CMS, it's defined as 4 different types of care: long-term acute care hospital, skilled nursing facilities, inpatient rehab facilities, and home health. But more and more, we want to know, what about hospice, palliative care, and surveillance therapy, which your acute care at hospital at home here at Mayo now has. Used to be, we'd send people to post-acute care, hey, let them go recover, recuperate, and rehabilitate some. As you know, our lengths of stays are being more challenged. Our post-surgical stays are more challenged. And now more and more, as we send them out of the hospital, they require medical and surgical management. It's services driven. They need therapy services, PTOT, speech, and we're changing it every day as we go and redefining these settings. Just for those for PAC for beginners, the dark blue line here is about the medical amount of treatment people receive at each place. Therapy services in red, so inpatient rehab facilities, you can see, is primarily therapy services, and the light blue is recovery. So the easy way I think about it is LTACs, people are very sick, usually ICU level of care, stay longer than 25 days. IRFs, you've heard the 3-hour rule. They get a lot of therapy, interdisciplinary teams. Skilled nursing facilities, this amount of therapy can vary quite a bit based on which skilled. And home health therapy, you're going to get a little therapy, but mostly it's going to be timed for recovery. Each of these levels of care, I won't go through with the time, but there's different services, and people have different eligibilities to meet the facility type. Just like for the acute hospital, each 4 of these levels of care have different criteria of whether or not I or you can send a patient to this level of care. Important to know. If you think the acute hospital is crazy, prior to a year or 2 ago, each setting had different regulatory issues, different ways to measure how people do, and different payments. Still, skilled nursing facilities are paid per day, LTACs per discharge. Home health used to be 60 days, it's now 30, and IRFs are per discharge. This will become important when we start looking at, again, the global picture of care for your patient, and in a limited resource world, is what resources can we use for that patient? Now, this is a picture from Institute of Healthcare Improvement of how things operate within a hospital. You can just imagine this is all in a hospital. Once we get to post-acute, expand this about 5 times over. And the Institute of Medicine studied this and said, just think about this for a minute. If there was no variation in post-acute care spending, the spending variation in Medicare would fall by 73%. So we're just talking Medicare here, and you can see the variation of what happens after people leave your hospital care. So one of the thoughts was, wow, there should be payment reform, value-based purchasing. We hear that in the acute hospital. Bundled payments, which we're going to hear, I like to think of it as episodic payment, ACOs, patient-centered medical homes. Probably the 2 things that have caught on are your value-based purchasing and your bundled payments. And really, are these bad things? No. We want to try and integrate care, coordinate care, share data, and health outcomes. So there has been in the past year some changes. We now use a current functional GG code across all settings. I can now say, wow, if I sent you to this setting, you improved this much functionally. We have not changed the way places are paid per diem or not, but we are paid differently in skilled nursing. This is an important in my world, is it used to be very therapy driven payment. It is now more medically driven payments in your skilled nursing facility models. Why is that important? If I send a patient that needs a lot of therapy and they can't get it, certain skilled nursing facilities may not be the right place to send them. And we see money does drive some things. Readmission reduction programs, when Dr. Nottmeyer and I were both starting at Missouri, we didn't want people to be readmitted because that means they had problems. Some people you're not going to avoid readmission because of the pathology, but there was no penalty. Once penalties were put in place, I can guarantee you every hospital has stringent programs and resources put towards reducing readmissions, which is not such a bad thing. One area that I have a lot of experience with and I've worked with is bundled payment models. Bundled payments are pretty simple in theory, hard to calculate. It's basically taking whether 3 days before admission or at time of admission, some type of trigger, and looking at a time frame and the total cost of care. And the idea is if the total cost of care is less than the average nationally, you would receive a bonus payment. If you exceeded it by a certain amount excessively, there would be penalty payments. So again, different models, concept is there of bundled payment. And back in 2014, and we'll look at that in 14, but it will have applications to today's care. We just look at, I was part of a reconciliation group or conveners for different centers, and you would join different groups. As you can see, major joint replacements, lower extremities, actually, this system made quite a bit of improvement with things. Their spinal fusion, cervical fusions, they had difficulties with. One of the things you might want to think about is major joints, you operate on healthy people, predictable. If you're in a spinal fusion and you're in a trauma center, it's very unpredictable in some of your costs. And just so you know, for the future, they could look at each physician and what was his or her cost for the care. Interesting, one thing they found out, and this will prove out later, bottom line is the blue bars, the x-axis represents total cost of the episode. The red bar is the cost in post-acute care after they leave your hospital. The blue bar was the cost during the hospitalization stay. This matched work done back in 2011 by Barbara Gage showing a lot of your costs, over half, and sometimes can occur after people leave the hospital. What's the big cost driver for some of these? If you look at each of these bars here, these are each individual patient episodes. The costs are represented on the y-axis. If you look, congestive heart failure, you can see wide variation in cost. And what is that? The primary cost driver is readmissions there. So if you think about it, congestive heart failure are very complex patients. Once again, our major joint replacement is going to be very standardized with just a few outliers. So again, why do I bring this up is as we look forward, these are things that you need to think about as we develop post-acute care patterns for patients. These patients, I may want to have a little more of medical touches after they leave to manage their failure. Why now am I excited about bundled payments or things like that? Because like we said, used to be before bundled and looking at this, we only looked at what happened after the hospital. Now it's critical for us to know, wow, where do patients go? Not just to sniff, not just to home health, not just to rehab, but which one? And what is their course? Do they require readmission or not? Did I put them maybe in the wrong place? Could I have better decided where someone may go? And how do I re-engineer my care after the hospital? But this re-engineering occurs in the hospital because that first place I send them determines the route and course of their activities. It's been shown that there are over 8,800 different variations in type and total count of unique post-acute visits after discharge. If you think back to the IHI schematic of what happens in the hospital, you saw those variations. Just think of this, there's 8,800 different types in post-acute. And it's shown that the first setting, the first place we send patients from general acute care hospital is a major driver and pathway of that overall episode payment. Again, we are now using payment as a proxy for quality and cost issues. So we want to think about one take home today is we don't want to discharge patients. What's a discharge from dictionary? To relieve of a burden or of contents or unload. We want to transition patients. We want to change them from one place, i.e. the hospital, to the right post-acute care place and transition. I worked with, this can be done, we did a Model 3 stroke bundled payment, BIPSI, and actually stroke has a lot of variation because usually does a patient have just one vessel disease? No, it's usually multi-vessel and multi-issues. We actually ended up showing a profit. How did we show a profit? We had less readmissions. We had more continuity. All we did was hire a care transition manager, and we had nurse calling patients. Did they get their meds? Did they get their appointments? Did they get X, Y, or Z? And we showed that we could cut down on readmissions and actually reduce costs and reduce morbidity for the patients we served. Where do people go after the hospital? You guys have some great setup already and great teams. Really, it's usually pretty clear where people go: IRF, home, LTAC, IRF, inpatient rehab facility, skilled nursing facility. These are the patients where I can make my most impact. Is there's a lot of overlap, and trying to decide, okay, early, this overlap patient, should they go to an IRF or a SNF for their first setting, or are we able to get them home? We place people because of multiple things. Their medical issues, readmissions. Functional issues, how do we get the best outcome? Social, what's their support? Geographic, where do they live? Do they have that resource where they live? I hate to say this, but it's true. Financial, do they have access to go to an inpatient rehab facility? Will their insurance cover it? Will their insurance cover a specific SNF? And lastly, patient choice. While it's always the most important, we need to help patients with an informed choice. Think about it medically. There's different levels of care out there. We have different levels of care. The medical care in the ICU is much different than the general floor as far as staffing of nursing, resources available. Think about it in post-acute. There's even a wider gap in the variation. There are a lot of tools we use to look at where do people go. If any of them work perfect, we would only use that. So whenever there's a lot of tools, we know there's a lot of variation. Here in at Mayo Jacks, they use the AMPAC scoring, the 6 clicks. Again, 6 clicks helps with function, but is not looking at medical, social, financial, geographic. So there's other factors that need to go in. One thing we did at Missouri was say, okay, let's see, do we have people going to post-acute? About 30% of our patients use some form of post-acute care. And 10% of all our inpatients discharged to our post-acute care partners. And we found that of our partners, we had a high readmit rate. So we said, let's look at this in detail. Just like you might think, different services use the different levels of care differently. Neurology tended to use a lot of inpatient rehab facility with their strokes. Surgery, where neurosurgery was under where we were at, 23%. And then skilled nursing and LTAC. We also then looked at, are we sending sicker patients there? What's our return rate? And we actually targeted different facilities to be within our program. And we developed a care transition network where we would tell our patients ahead of time, you have choice, here are our partners. So we can help direct patients to the appropriate levels and follow the choice issue that are required. We did show some, by working especially with our SNFs, we dropped our readmission rate quite a bit over the years. We were still on a downward trend when I left Missouri, and some of that was just a Hawthorne effect of meeting and talking. Some of it was setting up specific programs in some of the different skilled nursing facilities. I look at your neuroscience discharges here at, these are Mayo JAX numbers. Same sort of thing, your post-acute care use is neurology and neurosurgery in 2020 were 33 and 29, roughly 30%. In 21, you're still at 30%. So again, the numbers are very similar to the amount of post-acute care utilization for your patients. We also have, I know many of you have probably already seen this, I got this from Nancy O'Keefe. We can look at our readmission rate by DC disposition and service line. For neurosurgery, the numbers aren't showing up here, but you can then look and say, targeting, should we look at which rehab facility, which skilled nursing facility? How do we set up the best care for each of these patients? And not only that is, at our post-acute facilities, are they getting amounts of therapy? It has been shown that if we give more dosing of physical therapy, occupational therapy in these settings, we have less readmissions after they leave these settings. Again, something we should be looking at to say, hey, how much are we getting there? What are we sending our patients to? Why is this important? Well, if you look at it again, for those of you who may not be familiar, MIPS or the Medicare Improvement Payment models that are looking at, wherever you go, wherever you're at, you're going to now start being paid on this value-based purchasing. This is what the weighting of the categories are. And if you look at cost, 30% of our MIPS score, which will be our Medicare adjuster on payments, and trust me, I believe in the future, our private payers will look, is going to be based on cost. And if you look down on here, intracranial hemorrhage or cerebral infarct, this includes all related claims 90 days post-trigger. So we're now responsible or going to be measured on the cost, not only during their hospital stay, but again, remember, this is like an episodic or bundled payment. All related claims 90 days post-trigger. So that's going to be the entire cost there for the 90 days. So it will make a difference. Where do we send people? Are they being readmitted? Not just from the human morbidity, but now we're looking at some of our other factors as well. And again, you can look at impact of weight of changes, all variable. Sorry on these two slides, this is episodic performance year because of some of the privacy of data. If you look at, this is knee arthroplasty, just like we thought before. Yellow is the facility cost, and most of your costs with knees happen in the facility. Oh, and for cerebral infarct, you can see the yellow is decreasing, doesn't come out as well. But what does that tell me? More and more of the cost is happening after the hospital, just like we saw back in 2011, comes true today. For those types of patients, we have greater costs after they leave the hospital. Why is it so hard to get all these things going? Well, as it looked at, we have a lot of non-partner providers we send out to patients and other settings. So it's hard to coordinate clinical practices and processes. There's no consistent EMR. Often communication, I would ask how many of you hear from your post-acute providers what happens after they leave here. Predicting risk in early patient. It's important we decide early with the patient care what level of care they're going to, and getting organizational buy-in to change some of these. Came here and I need to be aware of national trends. Remember, wherever you go, wherever you practice, all things are local. You have to know what's happening in your local environment. So one thing that they had asked me to start thinking about is, wow, for post-acute, do you buy it? Do you build it? Or do you partner? And I was thinking, I wonder what Mayo does here. I know different places. Finds out there's a lot of things going on here. Your advanced care at home has post-acute in it. This is Dr. Maniaci's one of his slides. But really, what is he doing? They're creating capacity to put people at home and treat them at home. They have their convenience and comfort. They use the technology for it. Some of this technology is Bluetooth home care that they are using. After they leave the acute hospital, they stay in a maintenance program for 30 days. So he has really actually set up post-acute in the home using the at-home technology. The question is, can we use this type of technology as well for some of our skilled nursing facilities, home health, or other things? We showed using just home therapy out in Missouri, just using home teletherapy. Our 30-day readmit for our COVID patients dropped only 1 of 19 versus 7 out of 27 who did not get home health. Once again, here, we leveraged our therapists and their clinical skills to quickly identify problems. You have many things going on here in Mayo, just so you know. You have your virtual hospital we talked about. They've just put in together a transitional clinic. So if people don't have primary care, they can be seen back within 7 days, because that's kind of a golden window to say, hey, did you get the right meds? Where are you going with that? Some of you know about the medical hotel. One thing, Cypress Village has 2 APPs that are Mayo APPs. Why is that important? People often come back because of medical issues, not as much for their functional issues. Fleet Landing is something that we're looking at to partner with for beds and have advanced practice providers there. And Brooks Rehab provides some excellent rehab. And the question is, do we know, though, how do our patients do that go there, and how can we work with them better to build relationships and coordinate our programs? Biggest problem is right now, as many know, we're still in some of a fee-for-service model. Quality is not rewarded as high as fee-for-service, and it costs money to hire a physician to develop this, or to take the time of APPs and put them out in skilled nursings, until these all take time. And when do we make that big jump to put all resources here or not? So what I like to call the acute hospital, and some of the work I'm doing, is called APAC. So post-acute care starts in the hospital. We want to work to reduce referrals to low quality people. We want quality provider investment preferred. We want to manage patient choice so they know where they're going. And we want to monitor our partners' quality and cost with ongoing communication, education, data, and shared care management. Some of the things we do in PM&R acutely in the hospital, we do spasticity management, agitation, arousal, storming, orthotics equipment. And one of the biggest things we do, you have a great system in place, but it's to assist with appropriate pack placement at the appropriate time. This is a slide just showing trying to get PM&R involved earlier in care. And actually at Missouri, we are showing this is the time to discharge. Neurology was consulting us much earlier in stays, as well as the neurosurgery department, 25 versus 19, to assist with helping with some of that post-hospital management. And if you improve, we know length of stay and throughput, small changes can have big impact on a cost of the patient stay, but probably even more important here in Jax is bed availability. I think since I've been here, the color purple is becoming ingrained in my head in reference to beds being available. The other big thing is to keep the Mayo brand. This was writing from a patient just the other day, and I was talking to him. He was on the vent, and he asked me, you guys have created a monster, because we were talking about going to inpatient rehab, and his first question to me was, does Mayo have inpatient rehab? Well, that may be something to think about down in the future. Do we get some beds for that? Right now, we need beds for our surgical cases and intensive care and transplant patients. This was a quick overview of post-acute care. I flew through it based on time. I'm always happy to talk to anybody on this. You'll see me on the floors walking in that round, hopefully. And if you ever have a question, feel free to call me or, hey, Greg, is this somebody you can help us with or consult on? Please don't hesitate to call. And this is my Gators and Mizzou Tigers. Never thought I'd see the two of them in the SEC together. And Dr. Nonmeyer, I hope we got through in time. I flew through a lot of things there.
Hey, Greg, thanks a lot. That was an excellent talk. I just had one question for you, a couple questions, really. You know, in Missouri, if you had a skilled nursing facility that didn't seem to be up to par on the care and you were getting a lot of bounce backs from, how did you interact with that SNF? Did you have an outreach to them, or did you contact them directly, or what was your process?
Yeah, we would actually, what we had put together, we were lucky, we had a post-acute care team, and we would reach out to them directly and review, okay, let's look at our data. These are people bouncing back. Why are they bouncing back? And developed relationships that way. And then we actually had, because of quality, we had 4 that were selected as our in-network providers. And we signed actually business agreements, addendums, to where we could share data openly. And it was kind of funny. They were so happy to just talk with us, believe it or not. And we developed the relationships that way and signed some BAAs.
And the other question I had with your COVID-19 study from Missouri,
yeah,
when the therapists were doing telehealth, were they just doing advising exercises over the phone? Okay.
Yes, it was just over the phone through video. And actually it worked out great because they could see the patient in their home setting. So for equipment issues, it turned out super. But yeah, it was just video.
Okay, so does anyone else have any other questions? They can raise their hand. Gaetano, I think you can probably see more so than I can who's raising their hand. So
I don't know how to raise my hand, but I can get in line.
Go ahead.
Okay. Listen, really great talk, obviously apropos to what's going on around here in medicine these days. So in the neuro world, and it's kind of a compound question, to see if I can articulate it. In the neuro world in particular, and in the academic world, we oftentimes have huge outliers. The occasional, you alluded to it several times, that the algorithms work better when things are more consistent, and the outlier. I mean, a lot of times everybody sort of says, well, okay, you have an outlier. We don't make too much of it. It's an outlier. But in our world, an outlier can be devastating to the bottom line. People who can't get moved to because there aren't appropriate facilities, or people who have devastating injuries, neurologic injuries that can't be taken care of except for tremendous things that require tremendous resources. And as an academic medical center as well, as a big tertiary center, we sometimes take on these very difficult cases without a lot of resources behind them as part of our teaching and part of our mission. How can you maybe enlighten us a little further? Is from what you see of what's coming, Are there going to be adequate resources allocated and exceptions made and calculations made for these kinds of wild swings that we particularly see with neuro patients?
Yeah, David, great point. Actually, with some of the bundled payments, they have stop losses. In other words, a ceiling where it hits on some of that. Yes. Some of the case mix adjustment. Yes. But I have some concerns, and this is where I actually do quite a bit of health policy work, is will there be, in a sense, and again, I'm talking totally different, and in the post-acute world, you have inpatient rehab facilities. If they take on patients that are less care, i.e. less resource utilizers, they have higher margins. And now we're talking a business model. So will they come take all the, what we say, lower level, just to your point, and then you have academic centers, i.e. not stuck with, have the opportunity to care for these patients that require higher resources. You end up with lower margins based on today's payment. And if we don't advocate for that, I see big trouble down the road.
Well,
I didn't answer your question, but
no,
there are
you
some
did actually in a
adjustments.
lot of ways. You
Yeah.
did actually in a lot of ways. And I see from a political perspective, you've
Yeah.
got places like inner city hospitals and stuff where their outcomes are you're going to have a very difficult time having similar outcomes because of the underlying comorbidities of the population and the more difficult things that they have with taking care of themselves and being aware of doing it. And so, the models, I don't know that if I'm just wondering, are people really looking at that as part of the modeling overall? Because I think it makes a huge difference and maybe more than people are willing to admit.
Yeah, you're right on the issue that also I have with bundled payments and all that. If you noticed, I talked money this whole time, and the money was the measuring stick. It's easy. People understand money. We didn't talk high quality metrics. I actually advocated and actually testified to Congress on quality issues and how they are not factored in here. So there's a lot of work to do on all these payment models. And if we stick our head in the sand, we're going to be stuck with what they give us. So I encourage everybody here to get involved, understand in some way, locally or nationally.
Yeah, great. That answers a lot of my questions. Thank you.
Yeah.
Are there any other questions for Dr. Worsowicz?
Well, Eric, I want to thank you and everybody here. Amazing work you do and what happens on the floors, and look forward to working with a lot of you.
Great. Thanks a lot for speaking today. It was an excellent talk. Very informative. All right. Thank you, everyone. Our epilepsy conference starts at 8. So see y'all later. Have a good day.